Hello? Hello? Can you hear me? Can you hear me? Hello? Can you hear me? Okay. Oh, can you hear me?
Yes. Can you hear?
Okay, great, great, great.
You hear me?
Yeah, because because I've not been hearing you. So anyway, so am I supposed to start now?
Yeah, the stage for you. You can start, Professor Jack.
Okay.
Yeah. Okay.
Okay. Good evening, everyone. Good evening. Good evening, friends. Can you hear me?
Yeah. Very good.
I hope you can hear me.
Yes.
Okay, great. Okay, great. So good evening, and maybe in Egypt it's good morning, right?
Yeah.
Is it good morning in Egypt or lunchtime?
Lunchtime.
Okay. Okay. So it's my honor to speak to all of you this evening. Evening in the Philippines, it's about 8 o'clock in the evening. And so for some of you, maybe this is just a review. For those who have previously heard me talk about the lumbar spine. And so I just gave additional information at the end of this presentation. So I will talk about the clinical ultrasound of the lumbar spine. And this is a very interesting area because a lot of times we approach it from different perspective. Let's say you're a physiatrist or a sports physician or an orthopedic surgeon or an anesthesiologist. So you see this from a different perspective all the time. So hopefully I can bridge that gap. But at the end of this presentation, you can ask questions and you can give comments as well. So here, okay. So when we do a lumbar ultrasound, we're using a low frequency curvilinear array in order to have more penetration. And of course, that the image is a little attenuated because as you can, the lower we go through the depth of the tissues, then the structures become attenuated in the process. So, but this is the only way we can actually see the images. And so we use 4 to 8 megahertz and for a depth about 6 to 10 centimeter deep. So what are the areas that actually generate pain in the lumbar spine? So this is very important because when we approach the lumbar spine, we should be able to identify which of those structures are actually the cause of the pain when the patient comes to us for consultation. So these are the possible sites for pain. You have your lumbar disc. That is very common. And a lot of times we always say that's the cause of the back pain. And so we have to do something. Then we have the facet joint. We have the dural sleeve. And of course, we have the dorsal root ganglion. This is a very interesting portion of this lecture, the dorsal root ganglion, because this is sensory. And this is participating in the generation of pain when we deal with low back pain. And of course, the lumbar nerve root. And of course, we have different segments depending on what level are we looking at. And we have your posterior longitudinal ligament. This also contributes to the pain. The dura mater are very important structures. And so basically, the lumbar spine is innervated by a nerve that actually arises partly from the sympathetic nerve. And of course, as you will see later on, it's also part of the ramus that exists from the intervertebral spaces. So we call this a sinovertebral nerve. And around this area, there are also a lot of neurotropic factors, which also releases pain generators in the form of substance P and CGRP. We will discuss this later on in detail. And in the sensory neurons in the disc, they are NGF sensitive or nerve growth factor sensitive and GDNF sensitive. Now you will later on discover that NGF is one of the components of regenerative interventions that we have to really understand and know, because in the process of trying to relieve the pain, we might in fact generate more pain as we try to include this in the treatment. And of course, it acts through your dorsal root ganglion. So the NGF and the GNF will work through the dorsal root ganglion, and because it is also innervated by the sympathetic nervous system. So if you look at the illustration here, the outer area of the annulus fibrosus is innervated by these nerves.
Dr. Jim.
Yes.
Please, I think there is a problem on presentation. I think just the starting bits only that we have on the share screen. Can you again to share
now, it? Can you see it now?
Just the
not yet.
Yeah. No. Please me.
Is it already? How about now?
Okay.
Is it see now?
The same
Can
one.
You see it already?
Sound of the lumbar spine. Just the only one pic, not the whole presentation.
Did you see the sinovertebral nerve? No.
No.
You don't see it?
No.
Okay, let me see if I can check the connection. Hold on.
Yeah, me, you can stop sharing and share again. Yeah.
Did you see it now?
No.
Hello?
No, the same problem.
You don't see anything?
Just the...
Okay, hold on.
Yeah. Yeah.
Okay, let me see what happened.
Yes.
Hold on.
Okay.
Okay, hold on.
Okay.
I'll try to retrieve.
No problem. Yeah.
I don't know what happened with this.
Yeah.
Okay, let me just try it once again.
Yeah. Can you move to...
Can you see it now?
Yes. Can you move to the next slide? Yeah. Yeah.
Okay. Did you see it now?
Great. Yeah. Yeah. Great.
Okay. Good. Good. Okay. Sorry for that.
Okay.
So, did you catch this slide on the pain generators?
Yes.
Have you seen this?
Yeah.
Okay. Yeah. Okay. Let me move on to the next slide. Okay. Sorry for that. Okay. So I was talking about the sinovertebral nerves, and this is the branch of the ventral ramus, and it usually innervates the outer layer of the annulus fibrosus together with the sympathetic nerve that goes with it. So sometimes this is the one that causes a lot of problems because of the fact that the interconnection of the ventral ramus and the sympathetic ganglion if you don't cover both of this area, it won't relieve the pain. So this is a very interesting part, because this is the one that actually causes much of the pain in the disc. And just for us to understand that this is coming from two areas in the spine. Also, in pathologic and degenerative disc disease, there is an upregulation of the nerve growth factor. And this nerve growth factor is very, very sensitive, such that it modulates the pain sensation that it picks up from the spine itself, coming from either the roots or the disc. Now, this is a powerful and selective nerve factor for sensory and sympathetic neurons, and it also controls the substance P and the CGRP. Remember, the substance P and CGRP are very important neurotropins that can also cause pain. So if you have the NGF, it will modulate the substance P, but at the same time, the NGF itself can also generate its own pain in the spine. And so when all these are interacting, then there is a pain that is felt in the lumbar spine. Now, to understand the nerve growth factor from the sense of the dorsal root ganglion, we also have to understand that the sympathetic trunk will innervate multi-level areas in the spine. For instance, L1 to L3 would be actually covered by T11 to L5. And L4 to S1 could be innervated by 2-3 levels above and 2-3 levels below. Right. That is why it is very important to recognize this uniqueness of the innervation, because a lot of times if we just focus on that area that we think is a source of pain, we might miss the other areas that is also innervated by this particular nerve. Now, here is an illustration of the sensory pathways in the lumbar spine through the sinovertebral nerves. And as you can see, it is widely covering a bigger area in the lumbar spine. And so if we approach a specific area, for instance, we might not fully relieve the pain because of the extent of the innervation of this particular nerve. Now, another thing is also to recognize that other than the dorsal root ganglion and of course the disc, we also have mobile structures that is participating in the mobility of the lumbar spine, which is actually felt at the facet joint. And this is an interactive mobility of the lumbar spine that can also add to the pain itself that the patient is feeling in that area of the spine. And here, when we do an ultrasound, we have to follow certain patterns. And this is a very simplistic way of scanning the spine to make it easy for us to remember using different images that looks like it. For example, if we are looking at the lumbar spine, a transverse view, referencing it from the spinous process, we can see both right and left, and you can see the peak, which is at the middle, is where the spinous process is. And of course, towards the lateral side, we have the articular process with the facet joint, and of course, the transverse process in the most lateral portion on both sides. So it almost looks like a tiara or a crown. So here, while we see this to be seemingly symmetrical, they are not exactly symmetrical, because in fact, if we put the probe right at the middle on the transverse view, we cannot see all those areas visibly, conspicuously on the same level, so that you have to adjust and do some tilting in order to visualize a specific structure that you would like to see. For instance, you are focusing your probe on the articular process. The moment you focus it on that area, then you might not see the spinous process at all. There is anisotropy that you will see in the spinous process as well in the transverse process. So this only means that the spine are not really symmetrical in the sense of how we understand symmetry. But there has to be some adjustment that we have to make as we scan them up and down looking for the structures that we are trying to target. Also, another pattern that we see here is that when we look at the longitudinal view, which we call the Paramedian Sagittal AP view, we would be able to see the facet joints here. And this is characterized as a camel humps. So the pattern looks like the hump of the camel back. So I'm sure for our colleagues from Egypt, this is very easy for you to understand. But for us who haven't seen yet camel, probably it might take a while before we can figure this out. But anyway, the pattern is just a repeating structure of the facet joint, and just posterior to that, of course, is the erector spinae. So if you adjust it up and down, you can see the same pattern. Of course, the size would be different, but at least the pattern would be the same. So focusing on that area, we will be able to see that structure. Now, as we move along, we move it more lateral, then we would see the transverse process. And you can also see a different pattern here because of the fact that there are interposing muscles in between, and the spinous, the transverse process that fits into the picture looks like a fork. That's why they call this the trident sign, because of the pattern that they see, those three bones that are protruding in between the muscle. And as they create patterns, then that is also the kind of pattern that we see. Now, if you look at the lumbar spine, it's very easy to check the structures because you can almost always just look at the pattern, and then you would be able to see what particular structure you're looking at. So this is just the way we would like to scan the spine. Now, another thing is to be conscious of the nerve supply that is present in the lumbar nerves. So for example, between L4 and L5, we expect that the nerve root that exists in that area would be your L4 nerve root. This L4 nerve root gives off two branches, one that goes directly on that same level of the facet joint, and one level that goes down to the next level below. We call that the descending L4 medial branch. Or if you are referring to the same level that we're looking at, let's say in this case, L4 and L5. So that is the L4 nerve root, but together with the L4 nerve root, it is also innervated by the L3 descending medial branch. So in other words, if you would like to target a specific nerve root that innervates that particular facet joint, we also have to consider injecting the level right above it to cover for both the level that we are targeting below. So in that case, we actually hit two areas, the L3 and the L4. The same holds true if you go up or go down. So each facet joint, in other words, is innervated by the two root levels, one coming from the same level and the other one coming from the level above it. So I think you have to remember that all the time. Of course, we still have a lot of other nerves that's coming from a lot of other branches, but these are not significant enough to cause problems in the lumbar spine causing pain. But at least we understand and we know that there are a lot of other nerves that goes into the area that we are trying to target, especially if you are doing a lumbar medial branch block of the nerve. Now, another thing here is that when we target the area that we are targeted by ultrasound, we have to understand certain thing in the lumbar spine that could guide us in approaching the lumbar spine with our needle. So for instance, in this case, we are trying to approach the lumbar medial branch. So in the lumbar medial branch, let's say it's between your L3 and L4. So the nerve there that we expect would be the L3 of that branch exiting from the nerve root and L2 descending medial branch. So we have to focus the probe right at the articular process, moving it to the side that we are trying to target from lateral to medial. And then focusing ourselves to the mammillary process of that facet. We would like to really target that area because that is where the nerve is located. the lumbar medial branch nerve is located right in that area. And of course, as we approach the needle on that area, it is very important to have a feel of that bone, because the bone is actually the site where the nerve really passes through or pass over it. And as we approach it, then we will be able to target the site that we are targeting when we do a medial branch block of the lumbar area at the specific level that we are trying to reach. So you can also change your probe position. As I've said, it is not totally symmetrical, so you can do it oblique, or you can do tilt, or you can do heel-toe pattern, just to be able to highlight the area that you would like to see, not necessarily all those areas of the transverse process and spinous process altogether, but you just have to see the area that you are targeting at the middle, which is the facet joint at the mammillary process. Now, another thing is, of course, we also target the sacroiliac joint when we think about low back pain. Now, what is important here when we approach the sacroiliac joint is the fact that the sacroiliac joint is composed of two regions. One that is actually covered by the interosseous ligament, and this is really the superior portion, which is really very, very tight, and the one that is just made of the synovial cavity, which is actually at the lower portion of the sacroiliac joint. Now here, your reference would be to scan this from the posterior superior iliac spine. When you put your probe on the transverse view, you will be able to see two foramina. The one that is closest, or that is proximal, is the sacroiliac joint, and the one that is more lateral is the sacral foramina. Make sure your needle goes into the sacroiliac joint and not the sacral foramina, because you might puncture the bowel as you go into that foramina. But also at the same time, that superior portion, as I've mentioned, is made of interosseous ligament. So most of the time it's very tight, it's very hard. So if you force yourself into that area, you will not be able to have a very easy access, because those are tough areas that's made up a lot of ligaments over that area. So you have to scan it and go downwards until you see a very small cleft where you can access your needle, and that is where you have to approach it. Again, approaching it from medial to lateral this time, because you are actually coming from the area wherein, if you look at the posterior superior iliac spine and you approach it from the more lateral view, the posterior superior iliac spine can obliterate the axis, so it will be harder for you to move to that direction. Now, this is how we approach it. So the angle is really very stiff, so you have to make sure that your setting, your depth is quite sufficient, and you can see the tip of the needle, the shaft of the needle as you approach that area, to ensure that you go to the right spot where you are trying to hit the sacroiliac joint. Now, another thing that is very important, of course, that some of you may be doing is your caudal epidural injection. Now, this is another alternative that we can use, especially for pain that doesn't respond with any other procedures, and that we would like to access the epidural area. And here, the reference would be the apex of your sacral cornu. And so if you do it on the transverse side, you can see the cornu on both sides, and you can see also the sacral hiatus, and you can also see the posterior wall just posterior to that, anterior to that, I should say. And then you can go up and down, scan the area, making sure where your axis would be, and estimating where you would like to approach it if you're doing it out of plane. But if you do it in plane, as shown here, you will be able to see other structures that will intervene between your sacrum and, of course, your sacral hiatus here. So the needle path should be angled sufficiently. So in other words, if you put the probe, you might not be able to actually see the entire needle in the beginning, because you have to move it a little posterior in order to estimate the amount of time that you can actually reach the area, until you see the needle tip going in, and make sure you go at just below your reference point, which is the sacrum. And then you have to, you can feel a certain give as you go in, and don't push yourself too much, because you might reach the nerve root level, which is really above that area. Now, another thing that is actually a modification of doing a block. For example, there are maybe patients who will be coming to you with pain extending up to your thigh, or sometimes going beyond your knee. You would like to find out what could be the reason for the pain that the patient may be feeling. So remember, we always sometimes attribute this to a radiculopathy, maybe coming from an L4, L5, or S1 level that radiates down to the leg. But it is also possible that there are actually peripheral nerves that could cause this as a result of some nerves that is coming from a higher level in the lumbar spine. The key for this is, for anesthesiologists, they use a Shamrock method or a lumbar plexus block. And this particular area is anesthetized, passing through the psoas major muscle at L3 and L4 level. And sometimes they go higher than that or lower than that, depending on what target you would like to do. But just for the information, everyone, you again use the facet joint as your reference, then move posteriorly. And as you move posteriorly, you can see the transverse process, and you go more lateral from the original position of your posterior. So for facet joint, transverse process, you go lateral, you can see the vertebral body. And you will notice that when you do that, you can actually see right at the tip of the transverse process, the quadratus lumborum muscle. Then on your left, you can see the erector spinae. Then of course, you can see the psoas major muscle right on the more anterior side. And that is actually the target of this injection. And actually what you are trying to target here are the three nerves: the femoral nerve, whose pain sometimes goes up to the anterior part of the thigh. Then you have the lateral femoral cutaneous nerve, which is found at the lateral portion of the thigh as well. And then obturator nerve, which is right at the medial side. So sometimes a patient would come with all these complaints that you cannot localize. Am I dealing with a femoral nerve? Am I dealing with a lateral femoral cutaneous nerve? Or I'm dealing with an obturator nerve? So sometimes it's very hard to distinguish all of them, because the entire thigh is just painful. And so this is a technique that you can use in order to approach those nerves at one target all at the same time. Now, the one that is shown here, of course, is the Shamrock method, but in the past, they have different technique of doing it. But just for our information, that these are the muscles that surrounds the lumbar vertebrae. And you have the quadratus lumborum, you have the psoas major right there, and you have the erector spinae. And then of course the reference areas that you use for targeting the osseous echogenic area that will serve as your reference that you are in the right spot when you try to inject. Now, these are the representation of the different methods. The one that you see on the left is the old approach of this injection. And as you can see, the needle comes from posterior going anterior. The Shamrock method was designed in order to see the needle quite conspicuously, and by moving it more laterally, you can see a pattern that looks like the Shamrock leaves of Ireland. And that is the reason why they call this the Shamrock method, because you can see those three muscles, that the pattern of the muscles are right there. And at the same time, you can see the location of the nerves that is embedded in the psoas muscle. So you will notice all those three nerves right there: the lateral femoral cutaneous nerve, the femoral nerve and obturator nerve embedded in the psoas major. So in other words, what this procedure is doing is to target that specific area in order to anesthetize those three muscles in the process of relieving the pain by a single injection from posterior to anterior. Now, other approaches that you can use is you can also individually inject the nerve wherever it came from. Let's say, for example, you would like to inject the femoral nerve right at the anterior part of the hip, or you can inject the lateral femoral cutaneous nerve just below your anterior superior iliac spine, between your tensor fascia lata and, of course, your sartorius. And then, of course, you can also inject your obturator nerve, which is, in fact, in between your three muscles on the adductor, your adductor longus, brevis, and magnus. So those two nerves, the anterior and obturator nerve, could also be individually hydrodissected if you would like to individually inject them depending on the complaint of the patient. So it is also important to realize that as we approach this area, there's a lot of arteries and vascular structures that we might see in the process of injection. And so just for us to understand that just close to the vertebral body is the aorta. Of course, it's on the opposite side. And of course, the other arteries are seen here to be also inadvertently injected if we approach this area. So we just have to be careful that we don't actually affect these areas as we approach them. So again, another representation of how this muscle looks like, depending on how we approach it, just for us to get a concrete view of how these muscles are arranged in the lumbar spine. Now, another way also of approaching this, especially if we are dealing with an individual nerve, is also, for instance, if there are no pain in the middle portion of the thigh, so we might just be approaching a femoral nerve or lateral femoral cutaneous nerve. So the other way of doing it is by approaching it through what we call the fascia iliaca. This is a painful area, and this is also a fascia where if we inject this area, then we could be targeting these two nerves. And this is very interesting because these two nerves runs anterior and lateral following a common fascia, and they call it fascia iliaca. So this is how to approach it. There are two ways. We have the infrainguinal and we have the suprainguinal. So here, as you can see, the fascia iliaca is bounded by the iliopsoas, and then of course the sartorius muscle, and then of course the femoral nerve on the other side. And there is a very thin layer over there that we can see, and that is where we have to position our needle in such a way that we will be able to approach this. As the fluid trickle down on those areas, it will actually distribute on those different areas. About 10 cc of fluids is sufficient to cover all those specific areas in the infrainguinal area approaching the fascia iliaca. Now, if we do it from the suprainguinal view, now you can also do it this way. So you just adjust your probe right at the level of the anterior inferior iliac spine. And then this is the structure that you can also see. So you have to put your needle just at the tip of the sartorius and also the iliopsoas muscle, and that is your fascia iliaca. Then you approach there, and that is where you put your fluid. Now, when you do this, you are only treating those two nerves, the femoral nerve and of course the lateral femoral cutaneous nerve. Now, another thing is, of course, we have discussed this earlier, the location of the nerve roots. And this is very important because as mentioned earlier, these nerve roots are exiting at the intervertebral foramen represented by the two levels, and the nerve root that comes out of it is represented by the level above it. And of course, if you think about the facet joints, it is innervated by the level with where it exists and the level that is above it, the descending medial branch. Now, the other causes of back pain that we sometimes overlook is the superior cluneal nerve. Now, a lot of times when we examine the patient, we will notice that the patient would experience pain right above the iliac crest. And on those areas, this particular nerve, which is purely sensory, L1, L2, L3, are the ones that innervates this particular area. And one that is very interesting here is that this nerve is injured when actually we do torsional activities. We rotate on one side, especially when we are transferring objects from one table to the next table, maybe where we rotate our spine. And in the process, since these nerves are found right on top of the iliac crest, there's a tendency that it will produce traction on these nerves and causes pain. So it could be visualized in the ultrasound, although not all of them could be seen, or only the intermediate side could be seen, the one at the middle. But the two, the lateral and the most medial ones, are not very visible. The one that is in the middle has a groove in it, and then that is where you actually have to put the needle in that groove, because that is where the superior cluneal nerve is exiting. So most of the time for physicians who are doing prolotherapy, they can actually trace these nerves and just inject it with dextrose water, and then the patient will have a relief of pain in that area. So that is how to approach this by doing the superior cluneal nerve. Now, the more interesting part, of course, is the degenerative disc disease. Now, this particular disease is very common in the spine, and as early as 25 years old, we can already have signs of a slow degenerative process. And what happens here is that there is a cartilage related disease that is already beginning to degenerate because of our repetitive activities. So some persons, they're repetitively carrying or lifting heavy objects, and it can actually herniates and hit the nerve that is located right posterior to that specific disc. And so we always try to blame the disc to be the cause of the pain. And so our intervention most of the time is to remove the disc in order to remove the pain. But let's see what the data shows us. So it's been found out that more than 40% of low back pain is due to the chronic degenerative disc disease. 68.8% of these patients will have the same degree of pain for the next 4 years. And 67.7% of these patients will return to work without any treatment. In other words, they can recover without any intervention at all. It could just recover by itself. And 26% return to work after fusion. So some of our colleagues would do surgical fusion of these patients. Only 26% of that would actually be able to return to work. And 27% of those who were treated from the 26% will have to require reoperation. And 11% of those from the 26% will actually progress to a permanent disability. So in other words, when we actually consider doing this procedure, we have to be very careful that we might be actually giving more permanent disability to the patients because of the rate of reoperation and the progression to permanent disability if we did not make the patient well with this degenerative disc disease. So there is an increased incidence of developing more problems in the process of treating these patients. The other thing that is very interesting here is that once we have one level treated, there is also a risk of adjacent level degeneration. So for instance, we are treating L5S1. After the surgery, it is interesting to know that it could affect the level above it. Or if you are treating the level above it, it is also interesting to know that the level below it and above it could also be secondarily affected. So we call that an adjacent level degeneration. So the key here is to inform our patient what are the risks of the procedure that we're trying to do for them, so that in the process they will understand what we're trying to do. Now, what is the pathogenesis of this degenerative disc disease? So initially, in the cartilage level, we have a protein substance which actually helps in the compressibility and elasticity of the joints in the form of Aggrecan. If the disc starts to degenerate, then the proteases will come into play and will start to try to degenerate the disc. Now, the degeneration of the disc will eventually release the matrix metalloproteinases, or the MMPs. And the MMPs which are released will eventually form a compound called the Fibronectin Aggrecan complex. And this is from the cartilage level of the spine. Now, there are ways by which we can actually analyze this particular compound, and it's also been used to actually diagnose patients with DDD by actually doing a test for Fibronectin Aggrecan complex. And this is very useful because even as we say this is an indicator of a joint pathology, the FAC also will help us respond as to what type of treatment do we need to do. For instance, if the patient turns out to be FAC positive, then we are sure that this particular patient would respond to microdiscectomy, or if we are not doing microdiscectomy, we can actually do steroid injection, and this will respond to that. And if you are doing also other interventions like A2M, this is also responsive to A2M. So in other words, if it is positive, then it will guide us as to whether we should do this first or go right away to surgery. So this test will help us do prudence in doing our procedures. Now, so how do we go about the Fibronectin Aggrecan complex? So actually this was developed by the Cytonix Corporation, and it's an enzyme-linked immunosorbent assay. And depending on where we are getting the sample, then you will have to subject it to this particular test. So when it's positive, it indicates that there is an inflammation that is primarily due to a cartilage damage. So in other words, there is a damage that has happened when it becomes positive. So it is a unique molecular complex associated with painful inflammation. And of course, this also identifies symptomatic disc by the process of molecular discography. So even if the disc is not yet fully degenerated, we can already use this test in order to screen patients who can be treated depending on what type of intervention we would do, and we will be guided upon as to what is the appropriate treatment for our patients. Now, another issue in the degenerative disc is in the synovial cells. Of course, this is in the facet joint, and this is the one that releases pro-inflammatory cytokines. Even as we believe that the IV disc or the intervertebral disc degeneration can also cause problems in the disc, it is also important to realize that the facet joint can also cause pain that may be referred to the back. And so the synovium from that area will release the pro-inflammatory cytokines in the form of interleukin-1 beta, the TNF-alpha or the tumor necrosis factor alpha, and then the interleukin-6. Now, this comes into play with leukocytes, And together with these pro-inflammatory cytokines, it releases the lysosomal enzymes and the MMPs as well. Now, secondarily, even as the pro-inflammatory cytokines are the ones already causing pain, it can also secondarily degrade the extracellular matrix of the disc. So now it compounds the problem because you have the pro-inflammatory cytokines, you also have a degraded intervertebral disc. Another thing also is that the TNF-alpha will stimulate also the substance P and the CGRP, which are the neurotropic factors. And this also will be released, giving rise to different added pain to the patients. But it is also interesting to know that these different pain mediators are treated differently by different solutions. For instance, if you are a prolotherapist, you can just use dextrose 5 water to block this area because it can inhibit actually the substance P through the TRPV1 receptor. So the substance P and the CGRP are blocked by the T5 water. If you're doing an A2M, it can also block the pro-inflammatory cytokines. This is the only solution that can actually block this area. And I will have to tell you that if you use PRP, the PRP has a lot of NGF. And if you will notice from the previous slide, I've shown you that NGF can compound the pain and can cause pain generators. So if you don't filter it or process it to remove the NGF, then you might also induce more pain in the process. So it would be better to use an A2M instead, because in A2M there will be no NGF there, and it will just target the pro-inflammatory cytokines. So I think this is the last slide that I have, and I would like to invite everyone on next year here in the Philippines. And of course, in ultrasound, we say you can only see what you know. And thank you very much for your kind attention. And I will turn over now the mic to Dr. Raghav for maybe comments or questions.
Great. Thanks for your time, Professor Jim. And any one of the attendees has any questions, please don't hesitate to put your questions in Q&A box to discuss anything you need from Professor Jim. Okay. If any question, don't hesitate, please. I think this this is a very informative and professional and practical presentation, Professor Jim. I think also there is a lot of new information for all categories of the medical subspecialties as physical therapy and rehab medicine, and also, as you mentioned, physiatrists and also pain intervention doctors and etc. But may I ask one question? What about the ultrasonography for the facet joint during dynamic motion? Any other clinical impact for some visualization of the narrowing hypertrophy of the facet joint during a movement dynamic? You got my question, Professor Jim?
Yeah. Usually, as I had mentioned earlier, when we actually scan the facet joint on a transverse plane, we do not see all the structures clearly altogether. As I mentioned, there may be an anisotropy of the spinous process, and then an anisotropy of your transverse process. So it is very important to put the target right in the middle in order to see the facet joint, and you can just toggle it. You can tilt it in order to see. Usually, if you are dealing with a degenerative disc with a patient who is more than maybe 40 or even 50 years old, you will already see some osteophyte formation. And it is very interesting. I don't know if I mentioned in my lecture, but the osteophyte formation is caused actually by the release of TNF alpha and from the stimulation that comes from the dorsal root ganglion. So if you have any problems with the disc and it releases the TNF alpha, it will produce your osteophytes right at the facet joint. And here, when you look at it, you can see formation of the osteophytes in that area. You can use it, as I've said, you can scan it on the transverse plane, or you can use it on the longitudinal plane. In the longitudinal plane, you can see the facet joint in a way that the facet will have two echogenic areas that is moving as you move it. And then there is a cleft in the middle, and you are sure that as you move it, you will be able to see that at the middle of the side is the cleft where the facet joints are. But for the purpose of injection, we usually suggest to do it from lateral to medial in order to actually see the needle as it approaches that area of the facet. Although some people would also approach it from a longitudinal view in plane in order to access the facet joint. But the point here is that you can see both from the transverse plane and also from the longitudinal plane.
Okay. I think you see the Q&A questions, yeah?
Yes. The first one here is, they would like to see the pictures of the Psoas compartment. Okay, hold on. I'm gonna go back to that.
Okay.
Okay, so
we already recorded this video.
Yeah. Okay, maybe he just like to see it again. So this is the psoas muscle with the nerve in between. So as you can see it, as you approach it from posterior to anterior, then you'll be able to see those neurovascular area where the nerves are located, and that is where actually you have to inject the needle. The next question is, which is most effective injection, PRP or corticosteroids or other medication? Now, as we know, corticosteroids is effective if you want a quick relief of the particular area that you'd like to inject, because sometimes you cannot inject as much as you want. You cannot do more than twice as much as you want in using steroids, because we know also that there is a side effect if you inject more than 8 milligrams. So here, if you are thinking about long-term effect, I would prefer PRP rather than corticosteroids. But as you will notice also in my lecture, I'm also concerned about the nerve growth factor that is found in the PRP. That's why I would actually prefer, and if you are doing it, I would like to prefer an A2M, because there's no pain that goes with it. We always know that when we inject PRP, there's always pain, maybe for 2-3 days, because of the presence of the nerve growth factor. And this is the one that's adding to the pain that the patient is experiencing as we inject. But between steroids or PRP, I would go for PRP. And then the other question is, what do you prefer to use when addressing pain of degenerative disc, PRP, A2M, or dextrose fluid? Okay, actually, if you are injecting right at the disc, the most effective, really, the literature would tell you that the best one is actually the bone marrow stem cells. But there are physicians using PRP anyway. When you are approaching the disc with all of these regenerative treatments, you have to make sure you have a sealant that goes with it. The sealant would be in the form of hyaluronic acid that would seal the area that you inject, because the moment there is a leakage on that disc, the leak areas would also stimulate an osteophyte formation. So it's very important that when you do an intradiscal injection, whether you're doing it under ultrasound or fluoroscopy, you should be able to add a sealant that would seal, that would form a gel where you actually inject it, so there's no leakage that could happen. Otherwise, you'll be fine. But for the simplicity of the procedure, I would suggest that you inject right, if you're, depending on what you would like to address, it's the pain or it's the degenerative itself. If you would like to address the pain itself, you can just use dextrose or A2M. But if you really want a regeneration, I would suggest that you use a bone marrow stem cells instead, because that is the more acceptable and that has a good effect on degenerative disc. But always remember to use a sealant in the process. And the other question is do we always use a spinal needle when you approach spine? I would suggest you use a spinal needle because the length will not be enough. Sometimes, if you would like to have a good leverage when you approach it, I would always suggest that you use a longer needle, a 4-inch needle maybe, which is your spinal needle, for you to have more room to actually redirect or to hit areas, hit targets that you are trying to approach. This way it will be easier for you. What is the spine intervention that can be done by ultrasound? Well, all of this that I have presented is ultrasound guided. So whatever you see here is done by ultrasound. And so you can actually see how it's being approached when we do all these procedures. So these are all the questions I've seen here.
Okay, let me thank you, give you my best wishes, and hope all will be safe in this isolation time and this critical situation. Thanks again, Professor Jem, for this very amazing talk. I recorded it and I will go it on our page. Thank you again. Hope
thank you.
Another time.
There's another question here actually on the chat room. Okay, somebody asked a question about the superior cluneal nerve.
Yeah.
Okay, so superior cluneal nerve, you have to use a linear probe. Yeah. You have to use a linear probe instead of the curvilinear probe, and then you have to put it right on top of the iliac crest. And then you can see a groove there when you put it on top of the linear groove, and that is where you actually see the intermediate branch of the superior cluneal nerve. So you have to really see that groove there in order to see it. So you have to shift your curvilinear probe to your linear probe. And there's a question also here about carpal tunnel syndrome. Yes. Well, I would prefer PRP for carpal tunnel rather than just corticosteroids. Yeah. Thank you very much.
Thank you very much. Okay. Goodbye. Thank you, Professor.
Yeah. Thank you.
Thank you all attendees. Hope all be safe in this isolation time. Hoping to join another webinar sooner. I think in next Tuesday we have a webinar with the Professor Dr. Adham Abul Futuh on the knee ultrasonography tips and tricks. Some issue at next Thursday on the electrodiagnosis for quantitative EMG. If anyone hope to or favor to join anything in electrodiagnosis, thanks again and again for Professor Jem, and goodbye.
Okay, thank you very much.
Okay, goodbye.
Thank you.